So this morning we had a poster spotlight discussion that looked at 4 studies which addressed lifestyle interventions or retrospective interventions and their impact on various outcomes in breast cancer survivors. One of the first study that we reviewed was a retrospective cohort study that looked at a large national database and looked at the impact of weight management therapy after breast cancer diagnosis on cardiovascular outcomes. Cardiovascular comorbidities or complications are a major problem for breast cancer survivors. Survivors are at an increased risk for cardiovascular disease. And so the authors looked at whether or not the use of a weight management strategy like nutrition counseling, for example, or bariatric surgery or weight loss drugs improved the rate of cardiovascular events. And indeed, that is what they found, that the use of weight management therapies lowered the rates of cardiovascular events in breast cancer survivors. One comment I'll make on that study was that despite that positive finding, less than 10% of patients received weight management therapy after a breast cancer diagnosis. So I think this points to an opportunity to incorporate more weight management therapy for our patients with metabolic disorders and obesity after a breast cancer diagnosis. We also reviewed data from a study that looked at a GWAS or genome-wide association study looking at SNPs and their association with AI-induced musculoskeletal toxicity. And this was an exploratory study in the prospective CANTO cohort, which had some very intriguing findings and suggests that there are indeed some alterations that may either predict AI-induced musculoskeletal toxicity or be involved in the mechanisms through which that toxicity occurs. So future studies are warranted that use these markers either as predictors or even targets for intervention to improve this very common toxicity associated with AIs. We also reviewed data from the MD Anderson experience with GLP-1 agonists or incretin mimetics, weight loss drugs for breast cancer survivors. The authors reported in a cohort of over 1,000 patients that the use of GLP-1 agonists was associated with modest weight loss, and maybe not as much as we would expect, and that the use of hormone therapy seemed to lower the effectiveness of these drugs for causing weight loss. I think this opens up the question of whether or not we should be either using higher doses or a different dosing and duration strategy of weight loss drugs for patients with breast cancer. They did show that there was an improvement in all-cause but not cancer-specific mortality in that retrospective cohort. And then finally, we reviewed a secondary analysis of a randomized control trial which tested a survivorship intervention in breast cancer survivors. And in the secondary analysis, they looked at the use of an EPRO instrument to identify patients at high risk for weight gain or at nutritional high risk, either through a high malnutrition score or through a high body mass index. And what they found was that using that EPRO instrument, there was promising data. This was an exploratory analysis indicating that a nutritional intervention might improve body composition parameters, grip strength, and concerns about weight gain. And these findings are supportive of the design of larger confirmatory studies using an EPRO risk stratification instrument to identify patients who need metabolic interventions after a breast cancer diagnosis.